Good morning, good afternoon, and good evening. Thank you for joining the Wilson Center's Maternal Health Initiative, along with UNFPA, the International Confederation of Midwives, the World Health Organization, and Johnson & Johnson for the launch of a new study, Impact of Midwives, which was published online today in the Lancet Global Health Journal. I'm Sarah Barnes, and I direct the Maternal Health Initiative at the Wilson Center in Washington, D.C., and I'm thrilled to be part of this exciting launch event. For those of you who are not familiar with the Wilson Center is a critical source of nonpartisan foreign policy research and analyses and serves a vital role in linking Washington, D.C. to the world. The Maternal Health Initiative, or MHI, is one of several thematic programs at the center, and we focus on decreasing maternal deaths, as well as issues related to global health, the healthcare workforce, sexual reproductive health and rights, and gender equity. The Maternal Health Initiative has had the privilege of partnering with UNFPA for the past 11 years on our Advancing Maternal Health Dialogue series. 2020 is the year of the midwife and the nurse, and this launch event is part of our Year of the Midwife series that's been made possible through the generous support from UNFPA and Johnson & Johnson. Thank you to our partners and to all of the panelists and my colleagues at the Wilson Center for making this event today possible. The significant role of midwives toward the improved health and well-being of mothers and newborn babies has gained increased attention during the Year of the Midwife. I'm not going to steal our panelists' thunder by sharing data from their study, but I will simply say that the potential impact of scaling up midwife-delivered healthcare in low and middle income countries could be a monumental step toward decreased stillbirths and decreased maternal and newborn mortality. This new study also brings attention to the field of midwifery and the need for greater investment in the profession, not only to increase the numbers of midwives, but to improve their education and training and regulations and their working environment to also keep midwives safe and healthy. Our panel today includes the lead author of this study, several midwives and contributors from UNFPA, ICM, and WHO, including a public health specialist who can share some of her on-the-ground perspectives for the significance of this study, particularly in low and middle income countries. The event today will also include closing remarks from our partner at Johnson & Johnson. Before I hand things over to today's moderator, I want to remind our audience that there will be an audience-led Q&A following the panelist discussion. Please submit questions to mhi@wilsoncenter.org. That's MHI for Maternal Health Initiative. My colleague, Dikshita Ramanarayanan, and I will review the questions, and then she will share them with the panel during the Q&A. Again, the email address is mhi@wilsoncenter.org. Please include your name and affiliation. You can also follow the conversation on Twitter @Wilson_MHI using hashtag Impact of Midwives or hashtag MHDialogue. Now it is my pleasure to introduce today's moderator, Annika Knudsen. Annika is Chief of the Sexual and Reproductive Health Branch at the United Nations Population Fund, or UNFPA. She became a teacher in midwifery before earning her doctorate in healthcare pedagogics. She also was a midwife advisor for UNFPA in Bangladesh and worked at the Swedish International Development Agency for a decade. Thank you so much for being here with us today, Annika. The floor is yours.
Thank you so much, Sarah, and thank you for that introduction. And let me also say good morning, good afternoon, and good evening to all participants. And I can tell you that we have 900 people registered for this event. I think that's really great. And it's really my privilege to moderate the panel discussion we're about to have in a year that have really presented us with such enormous challenges and turned all of our lives around. The direct effects of COVID is of course devastating, but the indirect effects, especially on women and girls in so many ways, and in particular by disruption of services, sexual and reproductive health services, contraceptives, and the effects on midwives at the front line, as the frontline workers they are, risking their lives to save others. It is then, I think, even more gratifying to present evidence that strengthens the importance of midwives as providers of essential SRH services and the impact they can have on maternal neonatal mortality and stillbirths. So as Sarah was saying, the article we are launching today, Potential Impact of Midwives in Preventing and Reducing Maternal and Neonatal Mortality and Stillbirths, a life-saved tool modeling study, long title, is the first in a set of publications to support and help implement the SOMI, the State of the World's Midwifery Report 2021 outcomes. And just let me briefly say something about the State of the World's Midwifery series. It started in 2011 with the first publication and the first report. The second report was launched in 2014, and now in the year of the nurse and the midwife, which actually stretches into 2021, it's time for the third report. So this will provide an update, evidence-based and detailed analysis of the present progress and future challenges to deliver effective coverage and quality of midwifery services. But it also aims to improve the evidence base to enable stronger policy dialogue within countries to strengthen sexual, reproductive, maternal, newborn health and adolescent health services. So this impact of midwife study is part of and contributes to this report in a very critical way. And we'll hear more about this today. It also projects results that very nicely lines up with the desired outcomes of the global strategy for women, children, adolescent health and the Every Woman, Every Child movement. And it is, of course, of use to all countries, no matter where they are with regards to saving maternal and newborn lives and preventing stillbirths. So before I go ahead and present the panel to you, we have a very prominent panel today. I just wanted to quote Professor Mary Renfrew from the University of Dundee in the UK, who in a commentary to this study stated, "These new findings build on and strengthen existing evidence on the impact of quality midwifery care in averting deaths and improving health and well-being outcomes. They should command the attention of the global community in the same way that a new drug or innovative technical intervention would. There is serious and long-standing underinvestment in international standard midwifery. Gender, social, professional, and economic disempowerment of midwives and the women they care for all contribute to this." So that's a pretty strong statement, and I think it sets us on for the panel today. So let me now go to the introduction of the panelists. We'll have a panel discussion for 45 minutes. We'll have approximately 20 minutes for Q&A, and I will, after the panel discussion, repeat the email address that Sarah repeated several times, but I will repeat it again. And then we'll have remarks from Johnson & Johnson, and then we'll wrap up. So let me introduce the panelists to you. So we have here Franca Cadet. Franca Cadet is an expert on midwifery and advisor on international maternal health with over 30 years of strategy and policy development, advocacy, leadership, project management, and partnership. She is currently the International Confederation of Midwives, ICM president, and she is a very strong proponent of humanized midwifery care and encourages midwives towards respectful care and a human rights-based approach. Welcome, Franca. We have with us also Elizabeth Iro, who is the Chief Nursing Officer at the World Health Organization, WHO. And before joining WHO, Elizabeth had more than 30 years too of experience in public health in the Cook Islands and regionally. As Secretary of Health in the Cook Islands, she implemented health reforms to strengthen the country's health system. She is a registered nurse and a registered midwife, as myself, and had previously served as the country's Chief Nursing Officer and Acting Director of Hospital Health Services. We have, as Sarah said, and Andrea will start, Andrea No, who is the main author of the publication. She's a researcher and data analyst with 30 years of experience designing research projects, conducting detailed analysis, and disseminating information and evidence. Her main interest is in sexual, reproductive, maternal, newborn, and adolescent health, with most of her recent work focusing on health system strengthening and the health workforce in low and middle income countries. We also have with us Petra Tenhope Bender, who is a technical advisor on sexual and reproductive health at UNFPA in the team where I work. She is a midwife and executive manager with a health professional and business administration background, and she has 20 years of experience in independent midwifery and the management and development of organizations and public-private partnerships in the international health arena. Last but not least, we have with us Jihan Salad. Jihan is a professional that has a Bachelor of in Health Sciences and a Master in Prevention and Public Health from the VU University in Amsterdam in the Netherlands. What I also would like to share is that after spending most of her life in the Netherlands as a Somali refugee, Jihan decided to return to Somalia at the age of 23 to serve women and girls in countries where the health challenges are the greatest. She has more than 9 years of international experience in the areas of maternal and reproductive health, youth engagement, gender equality, and humanitarian response. So we really have a very varied and very interesting panel. Now we'll go into the panel discussion, but before so, I promise to give you the email address again. So while the panelists are presenting, discussing, and interacting, you can submit questions to mhi@wilsoncenter.org. And please indicate, as Sarah said, your name, your title, and affiliation with your submitted question. So let's go into the main event of today, the panel discussion. And I will actually start with Andrea to sort of set the stage for us. And really, as the main author, my congratulations to this launch and this article hot off the presses. It was actually disembargoed at 11:30 UK time last night. So recollecting Mary Renfrew's strong statement, I'm sure the audience is more than eager now to hear what were the headline results from the study. And what does this study add to what we already knew? Over to you, Andrea.
Thank you, Annika. I'm just going to share my screen. I have a few slides to share in order to answer those two questions. I hope everyone can see that. I'm struggling to get it onto SlideShare. There we are. Okay. Thank you, Annika. It's a great pleasure to be here today. So my job here is to just share some of the headline results from the study. Before I do that, I would just like to acknowledge the list of authors whose names you can see on this first slide. It was a real collaborative effort across several people across 5 different organisations, the logos of which you can see at the top of the screen there. And I would like to thank my co-authors for a real pleasurable collaborative effort. And I'd particularly like to highlight the contribution of Ingrid Freiberg, whose technical expertise really strengthened this study and makes the findings, I think, a lot more robust. So, so thank you to Ingrid. And also I'd like to thank the authors of the 2014 second paper in the Lancet series on midwifery, because their work really set the basis on which this study was carried out. So first of all, what did we do? We identified 31 what we called midwife-delivered essential interventions. And to count as a midwife-delivered essential intervention, it had to be something that directly affects mortality or nutritional status. There is a proven link between this intervention and mortality or nutritional status. They had to be listed in the Global Strategy for Women's, Children's and Adolescents' Health as an essential intervention. And there had to be something that can be delivered in their entirety by a midwife, if that midwife is educated to ICM standards and working within an enabling environment. So with that list of interventions, we used LIST, the LiveSave tool, to estimate the number of maternal deaths, newborn deaths and stillbirths that would happen each year if current rates of coverage of those interventions were to stay static to the year 2035 in a total of 88 high mortality countries. These are the 88 countries which account for more than 95% of the world's maternal newborn mortality and stillbirths. So we have that baseline scenario. What if these coverage rates stayed the same? And then we compared that with 4 different scenarios. The first one we called the modest scale up. So this is where each coverage rates of those interventions increased by 10% every 5 years from the baseline. The substantial scale up scenario was similar, but we have a bigger scale up, so 25% increase in coverage rates every 5 years. The third one was the universal coverage, which is where we projected what would happen if 95% or more of those who needed these interventions got them by 2035. And also an attrition scenario. So what would happen if there was a decrease in coverage rates of these interventions, such as might occur if there was a country with population growth and production of midwives wasn't keeping pace with that population growth. And you can see the results on this next slide. So we're showing here the 3 growth scenarios. So on the left there, we can see what would happen if universal coverage of these interventions was achieved by 2035. And the model suggests that this could avert 2/3 of the maternal, newborn deaths and stillbirths in these 88 countries. And if we project that forward to 2035, taking into account the population growth that's likely to occur between now and then, that would translate to 4.3 million fewer deaths in 2035 than we would see if those intervention rates stayed at the rates that they're at today. The substantial scale up, the middle scenario there, the 25% increase, this was the scenario that we felt was the most appropriate balance between an ambitious scenario, but also something that is achievable. It's entirely possible to see these kinds of increases with concerted effort. And these results show that about 40% of the maternal and newborn deaths and about 1/4 of the stillbirths would be averted in 2035 under this scenario. And that would translate to 2.2 million fewer deaths in 2035. And finally, on the right-hand side there, you can see the results of the modest increase, the 10% increase in coverage every 5 years. And this is the kind of increase which we know is possible. It has been achieved in several countries in recent years. And here we're looking at 23% of maternal newborn deaths averted and 14% of stillbirths, translating to 1.3 million lives saved in 2035. We also looked at which of those 31 interventions had the biggest impact on these mortality figures. And we found, as I'm sure most people would expect, the main one was modern methods of contraception. That was responsible for about half of those averted deaths, and an even larger proportion in the least developed of those 88 countries. In addition to that, when it comes to stillbirths, it was hypertensive disorder case management which had the biggest impact. For newborn deaths, it was the 4 or 5 interventions listed there. And for maternal deaths, those 3 interventions listed there, in addition to contraception, had a big effect relative to the other interventions. So Annika's second question was, well, what does this study add to what we already knew? And I would say it adds a few things. The main ones of those is confidence. So although this is based very closely on the methodology used for the second Lancet paper from 2014, LIST has been significantly updated since 2014. And the baseline data, the estimates of where we are have been refined and improved, and the way the model works in terms of linking these interventions with mortality rates is a lot more nuanced than it was back then. So the fact that we're still getting these really strong estimates of the impact of midwife-delivered interventions, we can have great confidence in the robustness of these data. And also it allows us to focus specifically on what we've called midwife-delivered interventions. Nobody's suggesting here that midwives should be left alone to deliver these interventions, but we did want to highlight the fact that they are an occupation group which can have a massive impact. And so that was why we restricted it to these midwife-delivered interventions. And I think that gives a very strong message there that could be used for advocacy and so on. The paper also adds some detail. I've shared with you just there the interventions that have the greatest impact, which is quite useful information. And also in the discussion of the paper, it goes on to, it doesn't just say, here we are, here are some numbers. It acknowledges the fact that there are significant barriers to achieving those numbers. and discusses what those barriers are and calls for action on some of those. And I'm sure that will form the discussion led by my fellow panelists. So I won't say any more on that at this point. And I'll hand you back to Annika. Thank you.
Thank you so much, Andrea, for that very comprehensive and brief. I don't know how you did that, but that was excellent. Thank you. And that provides really a very good basis for the discussion that we're going to have with also the other panelists. So let me turn to Franca for my next question. You know, reading the paper, listening to Andrea and having been part of also the development of this, what do you think is really why is this paper so important for midwives, but also for women alike?
Am I going? I'm so sorry, I just need to unmute. I have unmuted now. Thank you, Annika, for that question. And I'm extremely excited. And I'm excited mainly because, you know, this paper supports and confirms growing scientific evidence that should be celebrated by every woman and every midwife worldwide. And of course, if we care about healthy families and a healthy future generation, it should be celebrated by everyone worldwide. Now, as you also know, midwives are predominantly women, and through the years, I've become more and more aware of the connection between women and midwives. Women and midwives have stood together from the beginning of time, and women and midwives have suffered the same sexist attitudes. The rights of women and midwives have been eroded for centuries. And there is a growing movement of women and midwives who no longer accept the situation, and a huge amount of rigorous evidence, like this evidence, that together with human rights activists is reclaiming women's rights as human rights. And with that, they are also reclaiming midwifery and midwives. And we know that the White Ribbon Alliance, for example, presented 1.2 million sexual reproductive health demands from women in 2019, where respect was at the top. And having a midwife by your side, it soon followed. And this research now, it just reaffirms all that. And as Andrea said, it makes it more nuanced, it gives us some more insights. Interestingly, this research looks at the 88 countries that account for most of the world's maternal, neonatal deaths and stillbirths. And it provides those 4 coverage scenarios. And if you look just at the modest scenario of increasing the coverage of midwife-delivered interventions by 10% every 5 years, it could avert 22% of maternal deaths. I mean, that's incredible. 23% of neonatal deaths, 14% of stillbirths. So with this modest increase, we could avert 1.3 million deaths per year by 2035. And the other scenarios, except for the attrition one, they only get better. So I'm sure, Annika, you can understand my enthusiasm. This is real, and we can no longer get around it, and we can no longer linger. We know that if any other intervention, as Mary Renfrew said, for example, a vaccination program, if that had the same impact as midwives or midwifery has, it would be implemented worldwide immediately. It would be picked up by the World Bank as a top investment. Interestingly, midwifery, the work of midwives, is also much more than just an intervention. So this paper talks about specific midwife interventions, but there are, of course, many more. And the interventions are often aimed at, interventions in general are often aimed at the short term, but midwifery supports physiological processes. Midwifery has a specific philosophy of practice that is built on trust, continuity of care, respect, equal relationships. Midwifery has a long-term impact, and this paper shows that. Midwifery is about prevention. Midwifery is about unison, is in unison with women. And midwifery also includes certain necessary interventions as described in this paper. So as we all know, the maternal neonatal deaths and stillbirths are the tip of the iceberg of many other sexual reproductive health and rights issues affecting women and babies worldwide. This paper shows that midwives can help to substantially and sustainably reduce maternal neonatal mortality and stillbirths in low and middle income countries. And in some other high income countries, the countries with the best outcomes when it comes to maternal neonatal death and stillbirths, and respectful care, these are often countries where midwives are respected, are educated to international standards, are reimbursed properly, and have been totally integrated into society. So look at your country, Sweden, or New Zealand, my own home country, the Netherlands. And interesting, midwives in these countries often have a wide scope of practice. And this paper talks about specific midwife interventions, such as the high impact of contraceptive care. And you often see in these countries, these high-income countries, they specifically integrate these kinds of, they have the widest spectrum of midwifery care. So they include contraceptive care, they include abortion services, antenatal care, breastfeeding care, cervical screening, immunization. So midwives are not only with women when they give birth, even though it is the heart of our work, of course. So what it boils down to is that women worldwide should have access to midwives who've been educated to the standards of the International Confederation of Midwives and who are supported by a team. And that magic word, the enabling environment. And we often hear that term, enabling environment. And as ICM, we will be developing tools to support us to understand what this enabling environment means. And we will also, with our members, with women, with our partners, hand in hand, support a movement for midwifery globally. If we implement this evidence, the world would look brighter, not just for midwives and women, but for humanity. And so that's why I'm smiling and optimistic. Thank you.
Thank you so much, Franca, for that passionate, really, contribution. And I also want to thank you for giving us all, the full picture. So to say that for us to realize what this study really shows us, we need to work on a broad spectrum of interventions, right? We need to look at gender transformative approaches. We need to look at the transform part, not just we have the evidence now on the survive part, but we really need to look at what enables midwives to actually be able to provide what this study points to. So thank you for that. And I'm now turning to Elizabeth, and the importance is, of course, here to understand how governments can be helped by what the study shows. And really, I think every government strives to reduce maternal, neonatal, and stillbirths, and struggles in many ways to get this. So how from your perspective, from the WHO work, and from the work with member states and governments, what importance do you think this study will have? Over to you, Elizabeth.
Thank you, Annika. Greetings to all those who are listening into this session today. I think from first of all, I'd just like to say congratulations to all those involved in developing this really excellent and much needed publication. From a WHO perspective, this paper is the most important publication about midwifery during this 2020 International Year of the Nurse and the Midwife. These findings presented should leave no doubt in the minds of ministers of health, education, and finance that midwife-led interventions have the potential to save lives of women and their newborns at a vast scale. We must remember, nevertheless, that in addition to these modeling exercises, we must continue to strengthen the evidence base and systematically review the evidence to promote appropriate investment. WHO acts as the Secretariat for supporting 194 member states. We are in a unique position, in a sense, to ensure that all governments have access to these findings for decision-making around investments for improving maternal and neonatal health and reducing stillbirths. This paper will help us, all of us, to continue to work towards achieving the SDGs and in implementing the global strategy for women, children, and adolescents' health. Our experience in supporting member states at country level has proved just how influential and effective data in this paper can be. For example, following the early data in the Lancet series on midwifery in 2014, an increasing number of countries have moved to strengthening existing competencies of midwives, and some are introducing new cadres of professional midwives. India, for example, developed its first national strategy for midwifery, using the evidence in the Lancet series for midwifery 2014. And they have begun a nationwide process of educating and training 82,000 midwives to international standards. That has a big impact on improving maternal and neonatal outcomes. We all know we need even stronger advocacy for increased investment in quality midwifery care. The best advocacy is based not just on passionate belief that midwifery is the best approach to save and improve the lives of women, newborns, and their families, but on using good data. With this paper, we can together really strengthen our advocacy efforts. To ensure implementation of these encouraging findings, WHO will continue to support countries to implement the 3 consensus points reached jointly by WHO, UNFPA, UNICEF, and ICM in the 2019 Framework for Action for Strengthening Midwifery Education for Universal Health Coverage 2030. Just as a reminder, these are that every woman and newborn should be cared for by a midwife, educated and to international standards, and enabled to legally practice the full scope of midwifery, and that the title midwife should only be used for those educated to international standards. That midwifery leadership should be positioned in high-level national policy, planning, and budgeting. And that as we are today, we continue to strengthen global collaboration to align education, research, evidence-based policy and guidance, as well as monitoring indicators and investments. One key message from WHO is that now is the time to act. We must take urgent action. It is unconscionable to leave more women and newborns to die when we know the potential impact of midwife-led interventions. Again, I say thank you to all those who contributed to this paper, to this huge contribution to the success of the International Year of the Nurse and the Midwife. We look forward to continuing to strengthen our collaboration with you all to make the ending of preventable maternal and newborn deaths and stillbirths a reality. Thank you, Annika.
Thank you so much, Elizabeth. And really, I'm so happy about, how this whole panel and all your interventions come together from different perspectives. And let me also say that the collaboration between our agencies and partners is really so crucial. I think what I heard really is very important that you mention is that it's not just ministries of health, right? It's the multi-sectoral approach that we need. And that links so much to what Franca was saying. We really need other ministries, other parts of society to acknowledge the role of midwives and midwifery. And thank you also for the call to action and for really WHO standing with midwives. That's really so important. So our next panelist is Petra Tenhop-Bender, and I would like you to, could you say something about how you see that what this paper means for midwifery and maternal health, but not only in developing countries, in very low-income country settings?
Thank you very much, Annika, and thank you for the opportunity to speak here and for giving me this wonderful task, which I wholeheartedly support. So I wanted to talk a little bit about what this means for midwives and other providers in countries, because the document, the report and the article has really given us a tool with which we can talk to governments wherever they are, in my developed Dutch country, but also in other countries, and show them what they're losing out on by not investing in midwifery care, especially during these times of COVID. I think there are some additional issues that get raised because of COVID being amongst us at the moment. So with midwives' specific focus on care for pregnant women and newborns, both from before pregnancy through to the early weeks of life, this is a continuum that doesn't exist in the same way in other professions. Yes, general practitioners have their patients or their the people that they care for along a whole life cycle, but this is a life cycle that looks at 2 people at least. Also, not employing midwives for the specific needs of women during these physiological processes that pregnancy and childbirth are creates a loss for everyone, because the focus on physiology wherever we are in the world is important as it's what really drives the whole process. Yes, there are moments when there are other interventions needed, but in general, women, families, communities, and governments kind of get a better result and a better coherence if there is this continued investment in midwifery across the life cycle. Then investing in international standard midwifery care is a solid investment that gives a very big return. And we haven't been able to produce the paper yet, but it's on our list for producing close to or shortly after the launch of the full State of the World's Midwifery report. And I'm looking at Andrea, who is going to be working with us and leading in that as well. And the return on investment really can help governments understand what the balance is between where you put your money and what happens with the outcomes of that money, and how you maximize the impact of the investments that you make in the health system, and specifically in midwives. So midwives' return on investment is also double return, not only on the life saves that we're talking about so much, but also on livelihood sustained, because the healthcare providers that provide this care also get a further, their livelihoods and the livelihoods of the families they care for are sustained by this kind of care. So optimizing physiological processes, strengthening women's own capacities, and thereby saving the cost of medical interventions are one of midwives' superpowers. Providing interventions for women and newborns, or referring in a timely manner as needed, are also a superpower, though very dependent on the capacity of the health system. So that's something that is important for governments to understand correctly. And then supporting the collaboration and the communication when women need to go to higher levels of care, so as to optimize the use and the cost effectiveness of health system facilities and resources, really adds to this equation of making midwifery care super effective. And then finally, looking at the health and the well-being outcomes, not just the health pieces, but how women come through a pregnancy and childbirth, how the family grows, what the impact is on their family within the community that they live, the reduction of mortality, of morbidity, the health and well-being improvements, and for example, also the successes of breastfeeding are important elements to take into consideration when we look at the power of midwifery care. So if we then talk about the last part that's important in this equation is the global strategy for women, children and adolescent health and the Every Woman, Every Child movement have 3 mantras: survive, thrive and transform. So midwifery contributes enormously to survive, and of course people then go on to thrive. But the piece that we haven't looked at enough, and that is very, very important in this area, is the fact that when a woman comes through pregnancy and childbirth and she's had a positive experience, and she's had, or even a negative experience, but she's had a good strength supported by the people around her to get through those things, she's transformed, she's changed in the way that she feels, where her position is in society, what she can manage, how strong she actually is, even if she didn't realize it when the problems might have started. And that is something that never goes away. When there has been that transformation in a woman, that kind of strengthens the whole community, the whole group of people that are around her. And I think that is something that is priceless and hasn't yet been researched and supported enough. So let me leave it at that, Annika, and thank you again.
Thank you, and thank you for bringing those elements back in also to the discussion, because I totally agree with you that the transform piece is something that we need to do. And maybe when we finish this first round of questions for the panel, let's come back a little bit to additional barriers that exist. But before that, I would like to introduce and ask Jihan to talk a little bit about the importance of data, and especially at the local level? How can we utilize data at the local level? And in particular in settings where we have so many settings in the world with protracted humanitarian crises, but also other pockets in middle income countries that are very low resourced. So from your perspective, what role does data play and how can it be utilized at the local level? Over to you, Jihan.
Thank you for the question, Annika. I believe that this new data comes at the right time, especially during this COVID-19 pandemic, where we have witnessed firsthand how the already limited resources put into midwifery care are being diverted to the pandemic response. And if anything, these new estimates make one thing clear, which is that investments in midwifery pays off big time. However, there are many challenges preventing midwives to achieve their full potential. In the study, it was mentioned that 60% of the preventable maternal deaths and 45% of neonatal deaths globally occur in humanitarian and fragile contexts. And I've worked in Somalia, where midwifery care is largely a neglected area. And you see the impact of this neglect in the estimates on key health indicators. For example, the lifetime risk of a 15-year-old woman dying from maternal causes in Somalia is 1 out of 20. It is also estimated that every day 45 stillbirths occur and 48 babies die before reaching their first month of age. And we cannot achieve universal access if we do not address the problems in midwifery education and practice. And what we see in crisis-affected countries in the Arab States region is that at the education level, there are limited teaching and learning resources available. The curriculum is not always up to standard, and there's poor regulation of private education. And what we see at the practice level is severe shortages of qualified midwives, an inequitable geographical coverage of midwifery, and regular stockouts in essential drugs, supplies, and equipment. In addition to that, and this was also mentioned in the study, midwives are also facing social, professional, and economic barriers, such as gender inequality, restrictions placed on the delivery of the full spectrum of midwifery care, and low or inconsistent payments. Nevertheless, I believe there is hope. There's a growing body of evidence to which this paper contributes to that show that midwives who are educated and regulated according to international standards can meet the majority of the need for maternal and newborn health care. And this has helped at the field level to advocate for an increased investment in midwifery education and practice. And as a result, just to take Somalia as an example, a national midwifery strategy has been endorsed. A training curriculum based on global standards have been adopted. And we also managed to launch a performance-based financing system of midwifery as a pilot project. However, more work needs to be done. If we look in Somalia and in other crisis-affected countries in the Arab States region, we are far away from achieving universal coverage. And this calls for a need for increased investments to be made in pre and in-service education, in setting up minimum standards for the enrollment of students, in licensing and recertification of midwives, in governing teachers' qualifications, and in promoting continued professional development and research. But it also calls for an increased investment to be made in regulating and setting up practice standards, in ensuring that protocols, guidelines, and norms are in place in health facilities, and in creating enabling work environments for midwives, where midwives are part of teams that are of sufficient size and skill. So we welcome the publication of this new paper because it confirms to us that midwifery is a best buy investment, especially in low and middle income countries. Therefore, we will use this data and we will work with midwifery leaders, associations, and civil society to mobilize collective action and to set up new national and regional policy directions and budgetary priorities in support of universal coverage of midwife-delivered interventions. So thank you again, Dr. Annika. It was very insightful to be sharing my field experiences. So over to you.
Thank you so much, Jihan. And I think you really listed, not just listed, but you gave really the country perspective of what is needed and what the barriers are and where there is a need for, I think, more studies and and more research. And I would like to, we have a little more time here for the panel, and I would really like to pose a question about this. When we listen to all of your experiences and all of your knowledge and all of the evidence that's there, it's so evident that we all know what needs to happen. We know what changes need to be there. And still we are not there. And of course, there are many reasons for why countries have a difficulty in investing, etc., etc. But from your perspective, and I would like to do a little round, from your perspective, what do you think is really missing? What have we not been able to fully address? I think you've touched upon it in your interventions, but I think to have a sort of a quicker round would really be very useful. So maybe anyone who would volunteer to respond to that, but really, what do you think is one of the key things that we need to address in addition to this data that we have today? Maybe start with you, Andrea. In your dreams, or in what you would really like to see happen to accompany research such as this, what do you think really would be other areas of research that you would like to embark on to help with all the remaining barriers?
I think, thank you, Annika. There needs to be a much stronger understanding of, I think we know what the nature of the barriers are, but I don't think there's enough operational research looking at how they actually, how those can be tackled on the ground. How we very often see quite geographically limited pilot studies, but getting those to scale seems to be a big barrier that I think needs to be addressed.
Thank you. And I think, going to scale is really one of the key things that we need to find out how we can do. Anyone else? Franca, please.
Great, thank you so much for the question, Annika. I think there are lots of things. I think it's complex, but there are two things that jump to mind for me. The first of all, it's that we do have this tendency to think that interventions are where we need to go. And interventions have, of course, really brought down the maternal neonatal mortality rate. Sometimes I feel we've been kind of picking low-hanging fruit. We need to look at the long term. And then it's often building relationships, having trusting relationships, giving quality care. That is where you can really, really make a big difference. And somehow in our societies, that doesn't get as much attention. I think that's often the gender issue. So that actually comes to the second part, the gender issue. That's why I link women and midwives, is that often when we say midwives can do this, it's said, well, yeah, midwives are not really strong enough. Midwives don't have the capacity. Midwives can and often have the capacity, but we have, our job has been we are often not legalized, we're often not educated properly, we're often not registered. And all these things make that we are not strong enough to stand there with women. So I do really agree what Jihan was saying, and also that we really need to make sure that we have really invest in education, regulation, and that will actually enable us to stand there strongly and be able to do what we know we can do. But a lot of it does come down to building relationships of trust, quality care.
Thank you. Maybe moving to Elizabeth, as WHO is the normative agency and really is a provider of extremely important both data but guidelines, etc. So in this whole discussion, where do you think we need to go stronger?
I think it's almost, I feel like sometimes you need to have a bottom-up approach, and you can mobilize the women and those in countries to influence politicians. I think sometimes you have to take that road. And I think experience in New Zealand in terms of midwifery care has shown us that it can actually work very well when it's mobilized. And I think the evidence that we presented today is key to actually saying if we don't do anything, this is what you get. This is the lives and that we risk. So I think, as Franca and Andrea has said earlier on, it's quite a complex situation. It's not very individual characteristic or component focus. It is about addressing the shortage of midwives within countries. It's about understanding where that shortage has come from, whether it's through the education pipeline or whether it's through the migration pipelines. So it's really understanding within countries where those critical entry points we can make interventions, key interventions, and suggest and articulate the evidence to support countries to make those decisions. So I think it's about regulations. It's about, what is the scope of practice for midwives within countries? So it's not as simple as it appears. And I like the word you use, Andrew, in terms of it being, perhaps we don't understand the, enough around the operational side of these findings that we have. What is it, how are we going to be able to support countries to make that shift? I think it's missing. And I wonder if this is something that Petra alluded to in terms of the survive, thrive, and transform concept. I think there's probably some elements of that. But I have to say it's not as simple as it appears. But I think we have data, we have evidence. I think we need to try and articulate that in our advocacy, because I feel, we can't afford not to do nothing. So how we take this forward, I think, is probably finding that the key to turn that would be really useful, but it's not as simple as it appears.
Thank you.
So we need, I just feel, just to end, I
Yes,
just feel we need a
yes.
lot more work to do around education, around regulations, and probably around leadership as well.
Yes.
Where is our midwifery leadership? Where are they in countries? Are they making the influence necessary to take forward some of these findings? Thanks, Annika.
Thank you. Petra, you alluded to Netherlands, Sweden, countries that have had a long development of midwifery and sort of struggled with these issues that we're talking about here. What do you think, what has been the key things for the Transform agenda, do you think?
Thank you, Annika. First of all, if you allow, I would just like to follow on from Elizabeth.
Please.
I really think that putting the information in the hands of women, the service users, the service seekers, the support seekers, is a key component that we don't do enough. It's not the only one. I don't think that it's the only way that we can quote unquote solve this, even though it would be a long-term something to solve. But I do think that in countries, for example, like New Zealand, but also in other areas, for example, in the UK, midwifery kind of took off and became more and more visible when women started asking for it. And that to me is the first step, no matter which country we are, whether in Sweden or the Netherlands, or whether we're in Somalia or somewhere else. Women standing up together with midwives to say, this is what we need and what we want is going to make a difference.
Thank you. So I turn to you. Yeah.
Sorry, I just wanted to add a little thing. I'm sure.
Yes, please go ahead. Please go ahead. This is an interactive discussion. So it's fine.
I just wanted to add to the speaking up of midwives, because I actually see many midwives speak up. More and more midwives are speaking up. I think the issue is not midwives speaking up. I think the issue is that midwives are not heard. And at times when we speak up, we are told to say different things. So we're told, oh, don't say it in that way. Don't say that. And I think, you can't have it two ways. When midwives speak up, then midwives speak up, and we have to listen. And I do agree with Petra and Jihan. When we do that together with women, that comes out most strongly. But I do think the world needs to start listening to midwives. We can speak up. We're quite a strong workforce.
Thank you.
Thank you.
And that's really important, because what I wanted to ask you, Jihan, is listening then to Petra and Franca. So, on the ground, in the communities, in the villages, in the hospitals, how can we really put this in the hands of women? How can we increase that demand side through this kind of data?
Thank you for the question, Annika. I do believe, I mean, as Franca said, like we need to listen to midwives because they know what they are talking about and they know how we could change, how we could achieve a transformation in increasing maternal and newborn healthcare outcomes. And I believe there are 3 ways that we can use this data, I mean, locally, particularly in humanitarian settings. I think one of the most important things is to make sure that we avail the research to key stakeholders on midwifery, such as midwifery leaders, associations, civil society, policymakers, and local development actors, so that they can use this data in their advocacy efforts. Secondly, I do also believe that we need to undertake awareness raising for all sections and groups of society about this new data, in particular in addressing the problem of maternal and newborn ill health and the potential role that midwives can play in averting maternal deaths, neonatal deaths, and stillbirths. And lastly, I think what is very important is we need to promote ownership and participation by ensuring that communities can take ownership for finding appropriate solutions to tackle their own problems. For example, by owning fundraising initiatives to support the coverage of the full scale of midwife-delivered interventions, and by promoting full participation of midwives in decisions and policy-making processes that affect maternal and newborn health.
Thank you. And that really alludes to also what Elizabeth said about leadership, and we need to invest in leadership. We need to understand what midwives need to become leaders, but also what others need to open up and avail for them to have that space. We have questions coming in from the audience, and I would like to repeat the email address, and we'll turn to those questions, but please send your questions to mhi@wilsoncenter.org. And before we do that, I cannot leave this panel discussion without also acknowledging that we have been speaking about the scope of practice for midwives. We've been speaking about how midwives can actually provide care and interventions in a broader area than just childbirth. And we are currently in the 16 days of activism against sexual violence against women. And my question is really, what role do you think midwives can play in also preventing gender-based violence and providing services in that area? Is that something that we should be exploring more, or do you think maybe that would also be putting too much of a burden on midwives? So it's just a hypothetical comment from my side, but anyone who would like to start on to say something about that?
I can say something, but I worry speaking too much as a midwife, but we're told to speak up, so I'm speaking up. I do think that midwives have a big role to play, and I think we can. We are with women, and we know that violence against women sometimes starts in pregnancy. So pregnancy is actually a time when we really need to be alert. And as midwives, we often come close to women. We are in the community. We come into women's homes. We see a lot, and we simply have the role. It is part of life, and I don't think it's too much. I think we're very, very aware. Again, we are women, so often we have it happen to us as well. So we know what this is about, and I think we have to call it. So I think it is that is what midwifery is also this section, this part of looking at these issues. And I think we do need education to support us in that, and we need support ourselves to be able to handle it and handle it well. But it is part and parcel of what midwifery is. And I think that the world should take advantage of that.
Thank you. Johan, you wanted to say?
Yes, I mean, the point that I wanted to share is that, I mean, sometimes midwives are the only healthcare providers that a woman has access to during her lifetime. And I believe, therefore, it is critically important that midwives are well trained to provide care for GBV survivors. especially during the COVID-19 pandemic, where we are requesting women and girls to stay at home as if home is always a safe option. We know that that's not the case. So it is essential that GBV services, such as shelters, protection services, and hotlines remain open to women and girls, even during lockdowns. And we have to also not forget that midwives are also at risk of abuse while providing essential care. And therefore, we need to create a safe working environment for midwives so that they could effectively deliver their work.
Thank you. Excellent points. Anyone else who would like to contribute to that before we move into the other questions? I think it was very well said by both of you. And I think it's an important statement that you make, Franca, as the president of ICM, because I think that the more holistic care that we can provide for women, the better. And so that we don't fall into the trap of thinking that we need to create new cadres for providing services to GBV. So I think now we will have a couple of questions from the audience, and I would like to encourage the panel to grab onto the questions that you really feel that you would like to respond to. And we have Dikshita with us, who will read out the questions two at a time, and we'll take it from there. I think we have a couple of them, right?
Thank you, Annika. So we have 4 questions, and the first 2 are, first from Haley Schramm of Global Water 2020. Given the important role that midwives play in maternal and child health, what is the role that WASH, or water and sanitation, play for midwives, as it is inadequate in so many healthcare settings? Does the report address this? And if so, what are the findings? Next, from Jeanette McCullough of the International Lactation Consultant Association. You mentioned the study addresses the nutritional needs of the mother-baby dyad. Can you speak to the impact of the role of midwives on lactation?
Thank you. So I'm not sure whether Andrea would like to start on the more study-related ones.
Yes, I can do, Annika, thank you. If I can take the second question first. So breastfeeding promotion was one of the 31 essential midwife-delivered interventions. And we did look at the impact that might have on breastfeeding rates. And we found that if we could get that intervention rate up to universal coverage, then the proportion of children under 6 months who are exclusively breastfed would go up from 37% to 55% in these 88 countries, which would have significant benefits, obviously for nutrition, but also bonding, health, cost savings, and all the other things that go with it. So I think that is, yeah, I'm glad we had that question. Thank you, Jeanette, and an important finding. WASH is a more difficult one. There wasn't a specific intervention about WASH because it's not a specific intervention. So it's more of a enabling environment issue. So I don't know if one of the other panelists wants to talk to that one.
Mm-hmm. So anyone who would like to speak to the importance of WASH and maybe what we need to do to find the relationships and the data for that. Petra?
As Andrea said, we didn't address this in the report specifically or in detail. There are a number of midwives and midwife groups that really address WASH, that work on this area. Anna Af-Uglas is the person who comes to mind in this regard. And she worked with WHO combining midwifery and WASH. Maybe Elizabeth has more details on that. I fully agree that it's very important to take this along, but to me, it's not just a midwifery issue, it's very much also a health systems issue.
Correct. Anyone else who would like to say something on, because the question on the breastfeeding was really also on the role of the midwife on lactation and breastfeeding, and I know that there is a lot there to be said, but anyone who would like to say something? Elizabeth?
Annika, if I can probably just say very briefly on the WASH question.
Yeah.
I think not to the study, but to what some surveys were done within WHO found that within training institutions, there were 40% of the surveyed facilities actually had no hand washing facility, which talks to the, the issue about quality education. What is that being taught within the education framework around countries when you don't have some of the basic necessities to do the job that you're supposed to do? So there's, for sure there's been some a lot of work done around improving enabling those environments, and WHO definitely for sure has been doing quite a bit of work around that that I'm aware of, and probably provide some links to that work.
Thank you. Anyone wants to speak to midwives and breastfeeding, lactation more generally? I thought that question had that aspect as well. Franca, did you?
Well, I think my answer will be very similar to the earlier one. Breastfeeding is part of midwifery. If you look at the essential competencies of ICM, breastfeeding is part of and when a baby is born, breastfeeding, the mother, the baby are one, and midwives have an extremely important role to play. And going back to the wash, that's similar to all the other kind of environmental issues that we have to deal with, whereby it's difficult for midwives at times to work well and in a safe way. I do think we need to look at the fact there's often a hierarchy as well. So sometimes those people, like midwives, we now know midwives can have such an impact, but sometimes midwives have less access to wash, to clean water, than other healthcare professionals who are higher in the hierarchy. We need to look at that well. But breastfeeding, that is part of birth and having a child, and that is part of midwifery, and midwives should be there to support women. It's a holistic thing, midwifery, and breastfeeding is part of it.
Thank you. Maybe if I, as the moderator, may I ask a question to sort of a more personal interest. I see that many countries have lactation nurses, which is more of nurses going into lactation. And what I hear you say is that midwife is really part of the midwifery scope of practice. Now, we have not only on breastfeeding, but on many issues, we have countries that have sort of developed new cadres for different parts that a midwife could take on. What would be your advice there? Because it's also, you don't want to go back on something you have developed. It's a bit tricky, right?
Yes, I think we do need to look at each context separately and have respect for where it comes from. So it can be very easy for me to say, oh, why is that there? Sometimes it's something that has come from within society, or women have demanded it, and I think we need to look at it from context to context. But I do think we need to be careful that midwifery is not cut up into little bits, and that we invent all these different cadres that do all different aspects, because what midwifery is the fact that it can do the whole spectrum. That is midwifery. So I would advise countries to try to invest in midwives again, if they have stopped investing, or to start investing in midwifery and midwives, so that they can take the whole spectrum. But midwives should work in unison with other people, with doulas, with lactation people, with traditional birth attendants, with indigenous midwives, with indigenous people who have certain knowledge. And so we should work together and work in context. But midwifery is a holistic thing. Thank you. Sorry.
So we have some more questions, Dikshita.
Sure.
Please go ahead.
The next two questions. First, what are some country-based strategies to encourage governments to use this evidence and this data to change their mindset and increase midwifery care and increase support for midwives? Next, from Vitor Varela.
How can midwives be added to the economy of maternal and new birth?
So how can they be paid appropriately and supported?
Very important questions. So shall we start with the one, how we can encourage governments to use this evidence to change the mindset? Petra, please.
Thank you. Yes, that's a nice question based on what I was saying before. So one of the things I think would be really important is to work with governments to appoint a chief midwife. I think that is the entry into changing a government's mind. But for that, in my experience, and others may have others, the midwives need to come behind that. And they need some lessons oftentimes, or some support in kind of entering into that policy space and entering into those negotiations to get a chief midwife there. Many of the development agencies are around to help, but it has to come from the midwives in a country itself.
Very good, thank you. Anyone else on that wish to add something? Shall we go to the second one?
Yes, Annika?
Yeah, please go ahead.
I just wanted to answer this question, and I think the findings of this research paper are very clear. A universal coverage of midwife-delivered interventions results in a massive reduction in maternal deaths, newborn deaths, and stillbirths. And I think that it is therefore important that this new data becomes available and accessible to everyone so that it can be used in support of evidence-based planning and policy making. And therefore, I think we need to engage with midwives, and we need to make sure that midwives who are interested to influence policies, attitudes, and behaviors, that they are equipped with this latest data and information, and to translate the research into policy and the policy into practice. I believe much more work needs to be done in identifying champions locally, in empowering them to engage in policy discussions, and in supporting them in formulating concrete action plans and a roadmap in support of the universal coverage of midwife-delivered interventions locally.
Thank you. The other question was, how can we add midwives and midwifery into the economy of maternal and newborn care? And one very crucial question that I think most midwives in every country, no matter they are high income or low income countries, how can midwives be paid appropriately? So anyone wants to? Elizabeth is shaking her head a little bit, and then she recognizes this discussion from, I think, own experience as well. It's a tricky one, but Franca, yes, go ahead, please.
Well, interestingly, you know, we discussed, for example, New Zealand, where midwives really, women really stood behind midwives and also fought for pay equity for midwives. Not very long ago in Iceland, it was women again. Via Facebook was a huge campaign. Women fought for pay equity for midwives. And this is again where midwives and women are joined. You know, midwives are women, mainly women doing women's work. And in the last year, we've had a lot of clapping, a great amount of clapping, wonderful, but clapping does not buy bread. And I really do think that we need to realize the impact it has and the investment that it is. So I think we do need to look at the investment in midwives and what the return on investment is. And that would, I think, also support governments to see that it is worth investing in midwives. And pay equity is part of that.
Thank you. So unless we have anyone else who wants to say something on that, I think there are a couple of more questions, Dikshita.
So one more question.
One more question, and I think that's where we're at in time as well.
So this question is from Dr. Trout from UPenn. Are abortions included in the reduction of maternal deaths from contraceptive services? If so, what % of this reduction is attributed to safe abortions?
Shall I take that, Annika?
Yes, please.
Well, I can start at least.
Yes.
Thank you for that question. Yes, abortions are included in the reduction of maternal deaths from contraceptive services. I was just looking at the figures in the paper here. So what the model is suggesting is that the increase in coverage of family planning interventions could reduce the number of abortions by approximately a third by 2035. So we're looking at fewer abortions, but the other side of that coin is the proportion of the abortions which are safe and unsafe. And in the same scenario, safe abortion service is one of the 31 interventions that would be scaled up in the model under that universal coverage scenario. So not only would there be fewer abortions under this scenario, they would nearly all be safe abortions. And that's why we'd be seeing the kind of figures that we're talking about. I don't know if anyone wants to say any more on that.
No,
May I add to that, Andrea?
Yes.
That I think often people think that midwives are there to help women have babies, but actually midwives are, in our profession, we help women to get pregnant at the right time, whereby they have the control over it themselves and they decide when, where, and how to have their baby. And abortion is part of that. And I do think it's great to get the figures from Andrea in this way and to see that it is part again of the services that we provide.
Thank you. I do see, Dikshita, you said this was the last. I do see that there is one more question from Jeffrey Smith, which I do think that we could have time, because I think it's quite concise, or I think the answer will be quite concise. So
Sure.
if you don't mind to read that as well.
Of course. So this question, what does the concept of substantial or full scale up mean? Does it mean total coverage of all births? Or does this mean reducing the percentage of births currently managed by nurses, general doctors, and obstetricians? So a little bit more clarification.
So I think this is for you, Andrea, as well.
Sure, yeah. So I think there are three issues here. So the first question, what does the concept of substantial or full scale up mean? When we talk about universal coverage, we're talking about 95% or more of the people who need that intervention receiving it. So it's not 100%, because there's recognition that there are various things that can get in the way of that. So universal coverage is generally considered to be 95% or more. I think another thing that comes in here with the question about, does that mean total coverage of all births? 95% of them, yes, but it's not just births, as Franca was saying. Out of those 31 interventions that are in this model, 14 of them relate to labour and birth, but the rest relate to things going on before and after labour and birth. So it's important not to focus entirely on the birth side of things. And in answer to that last point there from Jeffrey, would this mean reducing the percentage of births currently managed by nurses, general doctors, and obstetricians? With that caveat in mind that it's not just about births, I think it's a very broad question. I mean, what we're looking at here is these interventions need to be delivered by somebody. So if it's not a midwife, then it needs to be somebody else. I think what we're suggesting here is that midwives can offer that full continuum of care, right from pre-pregnancy through to the postpartum stage. And also, I think we need to take into account that in many countries, nobody's attending the birth. So it's not about taking work away from nurses and doctors. It's about making sure that every woman is attended by someone who knows what they're doing. So I suspect other panelists may want to chime in on that as well.
I think you did very well on that, Andrea, and I think the question was more on how the study was sort of formulated and what was measured. So thank you for that. So let me then, at this point, thank all of you panelists for a very, very rich discussion, and also for being on time with your time limits, but most of all, making this a very dynamic and interactive session, which is not so easy in these virtual days and times. So I think I myself have enjoyed the discussion very much, and thank you for your very rich contributions. So now it gives me great pleasure to move to our next agenda item, which will be some closing remarks from Mei Li, or from Chun Mei Li, I should say, is your full name. She's the director at Johnson & Johnson Global Community Impact, which oversees Johnson & Johnson Foundation and Social Impact Initiative. Mei has over 10 years of experience in managing global maternal newborn programs and partnerships, and she's currently leading the Global Midwifery program for the Foundation's Center for Health Worker Innovation. So over to you, Mei.
Thank you, Annika. Can you hear me all right?
Sure.
So I was just told that we have 10 minutes. So before I go into my closing remarks, I just want to add a couple points that was discussed among the speakers. And then one is my experience in the space, and I want to emphasize the importance of a strong midwifery associations in country in terms of advocating for maternal newborn health and advocating for investment in midwifery. And the second point I want to make is the partnership with other cadres, including neonatologists and obstetricians, and Franca had plenty of experience in that area. And I think one of the speakers mentioned that it's not midwives alone. So I think partner with women is important, and partner with other cadres that affect midwifery care is also critical. And the third point I want to make is when it comes to advocacy, particularly for compensation. And so the work that I'm involved in, with including midwives, including nurses, including community health workers. So when you advocate for specific cadre, it's very difficult for policymakers, for government, for insurers. And what worked well in some countries is advocating for the services that the cadre provide. So when you want to advocate for investment in midwifery and making sure that you are advocating for the services and be clear about the services that midwives provide. So these are the 3 points I want to add. So I will go to my closing remark. So I do want to thank you, say thank you to our co-host, UNFPA, and the Wilson Center for putting this amazing virtual event together. And it is my great honor to be among the prominent and distinguished speakers today. And obviously a huge thank you to the 911 participants who tuned in today and shared your questions and comments. So Johnson & Johnson has a long history in maternal, newborn, and child health. With our partners around the world, we have helped address some of the toughest health issues affecting women and children, issues such as obstetric fistula, postpartum hemorrhage, preterm births, birth asphyxia, and other birth complications that could lead to mortality and morbidity of women and children. So how we address these issues are mostly through investing and supporting frontline health workers, such as midwives. I would like to share a quick story. And many years ago, I met a nurse/midwife during our meeting, and she expressed the utter desperation and helplessness she felt when she did not know how to help a newborn experience the childbirth complications. She burst into tears and told me that if a baby died or suffered a long-term disability, she blamed herself. So what I also learned that she graduated from nursing school with little formal training in midwifery, and it was assigned to labor and delivery, and she had to learn on the job. So she was not taught on how to manage newborns who can't breathe immediately after birth, because she was trained as a generalist nurse. And managing newborn resuscitation at the time was not part of the obstetric nursing scope of practice. So as one can imagine, obviously, when a baby dies or woman dies, it's horrible for the family. But for the health worker whose job is to take care of women and children, but who was not trained and does not have the skills to do that, and how demoralizing that felt. And luckily, the situation has changed in her country over the years. But unfortunately, what she experienced is not that uncommon around the world even today. So at Johnson & Johnson, we believe in order to achieve good health for all, we must invest in people who are at the center of delivering the essential services. In September 2019, we launched the Center for Health Worker Innovation, prioritizing nurses, midwives, and community health workers who make up most of the primary care workforce. This shift from specific health issues to cross-cutting frontline health worker workforce allowed us to ask questions differently, centering around the pressing challenges experienced by the people doing midwifery work. So now we're confronted with systematic issues that speakers had mentioned, such as the quality of pre-service education, scope of practices, licensing, and training staff that point to foundational improvements that needed to strengthen practice. So this led to our new partnership, I'd like to announce, with UNFPA and ICM to strengthen midwifery education so that a midwife entering the profession will never again find herself in a situation where she has all the heart to save lives, but not the skills to do so. And I hope every midwife is empowered to perform to the best of her ability. Now we heard the impact of midwives, millions of lives to be saved with increased coverage of midwife-led care. We need to take actions, spread the key findings, and invest in midwives. Investing in midwives is investing in women. Investing in midwives is investing in children and the future of humanity. So with that, I will turn back to Annika.
Thank you, May, for those powerful words of conclusion. And that really brings us to the close of this session, but really brings us back to where we started, which is this study, which is this hard evidence, which is this very important evidence for moving forward, for changing, to move into the transformation that's needed. So I really wanted to really end by congratulating everyone again to the publication. And just to wrap up, finally, is to say that this event recording will be available on the Wilson Center event page by the end of the day or tomorrow morning. And also that a summary of today's event will be available on the .mom column of our blog, of the Wilson Center blog, New Security Beat. And by that, I just want to thank everyone for tuning in. And bye.
Thank you for being such a wonderful chair, Annika.
Thank you.